next paper, pulmonary hypertension in CKD patients undergoing hemodialysis. Dr. Subramanian.
So good morning, one and all. I am Dr. Subramanian, and I am presenting this study from Sundaram Hospital, Trichy. And this study is about the impact of vascular access location on the severity of pulmonary hypertension in CKD patients undergoing hemodialysis. CKD patients undergoing hemodialysis have a high burden of pulmonary hypertension, and pulmonary hypertension is an independent predictor of mortality in CKD-HD patients. And it is feared that the most preferred long-term vascular access, AV fistula, might itself contribute to the pathogenesis of pulmonary hypertension. For example, a longitudinal study found that shortly following creation of AV fistula, the pulmonary arterial pressure briskly surged to the tune of 21 millimeter. And we all know that by ligating the fistula or by doing a surgical flow reduction, pulmonary hypertension could be alleviated. And there is also evidence that the blood flow in AV fistula correlates positively with the severity of pulmonary hypertension. So all these observations establish a link between AV fistula and pulmonary hypertension. So what we wanted to assess in our study was whether the location of AV fistula could influence the severity of pulmonary hypertension, because we surmise that proximally located brachiocephalic or brachiobasilic fistulas have higher blood flow than distally located radiocephalic fistula, and so proximal fistulas could be associated with a higher severity of pulmonary hypertension. And to evaluate this hypothesis, we conducted a cross-sectional study of CKD patients undergoing hemodialysis in a single center, and we included adult hemodialysis patients. Both incident and prevalent patients were included, and patients who were known to have cardiac shunt, who were known to have rheumatic heart disease, who were known to have obstructive sleep apnea, restrictive or obstructive pulmonary disease, and SLE connective tissue disorder were excluded. So the primary exposure of interest in our study was access location, and the primary outcome that we wanted to measure was pulmonary arterial systolic pressure. We all know that it has been already established that pulmonary hypertension in CKD could be influenced by dialysis vintage, age, sex, LV systolic function, left ventricular hypertrophy, anemia, and systemic hypertension. So all these confounders were included as covariates in our regression analysis. So in each patient, the vascular access was categorized as proximal AV fistula, distal AV fistula, or central venous catheter. And the outcome pulmonary arterial systolic pressure was measured. It was estimated using Doppler echocardiogram. So we looked at the TR jet and we used the modified Bernoulli equation. And the blood flow in the axis was measured using Doppler ultrasound. For both proximal and distal fistulas, we measured the blood flow at the brachial artery 2 centimeters above the elbow crease. So we looked at the vascular area and time average mean velocity to measure the blood flow. So the outcome variable, pulmonary arterial systolic pressure, which is a continuous variable, it was modeled using multivariable linear regression. So out of 116 patients, 97 consented to participate, and 7 had to be excluded because of COPD, obstructive sleep apnea, SLE, and rheumatic heart disease. So a total of 90 were included, and the most common vascular access was proximal AV fistula in 45%, followed by distal AV fistula in 38%, and 17% had CVC as their vascular access. The median dialysis vintage of the entire sample was 1.5 years, and there was no difference between the median dialysis vintage of patients with proximal versus distal fistula. The mean age of the sample was 53, and 60% were men. And what we observed was that proximal fistulas were associated with a higher blood flow. The blood flow in the proximal fistula was 1246 mils per minute, while that in the distal fistula was 783 mils per minute, with a mean difference of 463 mils per minute, which was statistically significant. And in this study, pulmonary hypertension was defined as a PASP more than 35, and severe pulmonary hypertension was defined as a PASP more than 60 millimeters of mercury. So in the entire sample of 90 patients, 81% had pulmonary hypertension. And compared to distal fistula, patients with proximal fistula had a higher prevalence of severe pulmonary hypertension, a 49% versus 26%, with an unadjusted odds ratio of 2.6, which was statistically significant. So this is table 1 that shows the characteristics of patients across 3 vascular access groups. And this table shows the outcome variable, pulmonary arterial systolic pressure. This is unadjusted systolic pressure, what we observed exactly. So in the proximal fistula, the blood flow was proximal fistulas were associated with a PASP of 63 millimeter, and distal fistulas were associated with a PASP of 48 millimeter, with a difference of 15 millimeter, which was statistically significant. So when we did the multivariable analysis, we found 2 things. One was the AV fistula, or the vascular access location. It had an influence on pulmonary arterial systolic pressure, and low hemoglobin, it influenced pulmonary arterial systolic pressure. So this graph shows that proximal AV fistulas had a predicted pulmonary arterial systolic pressure of 66 millimeter, while distal fistulas had a predicted pulmonary arterial systolic pressure of 44 millimeter. So there was a significant difference of 21 millimeter. So we observed 2 important things. Firstly, proximal fistulas were associated with a higher blood flow. Secondly, patients with proximal fistula had a higher pulmonary arterial systolic pressure. So we wanted to correlate whether there was a correlation between the access blood flow and pulmonary arterial systolic pressure itself. So there was a positive correlation with the R value of 0.31. So when access blood flow was included as a covariate in the multivariate linear regression, then the association between the access location and pulmonary arterial systolic pressure, it ceased to exist. So what it implies is that proximal fistulas are associated with a higher pulmonary arterial systolic pressure by virtue of a higher blood flow. Another ancillary but important finding in this study was that anemia contributed to pulmonary hypertension. Every 1 gram decline in hemoglobin was associated with a 4.2 millimeter increase in pulmonary arterial systolic pressure. So to conclude, the exaggerated pulmonary hypertension seen in patients with proximal AV fistula is attributable to the higher blood flow in proximal AV fistula compared to distal AV fistula. So this study, it reinforces the KDOC recommendation, vascular access recommendation, to adapt a distal to proximal approach for AV fistula creation. But the main rationale given by KDOC is that you have to preserve the proximal veins. And this study brings out another important reason why we should start with the distal fistula and then progress to a proximal fistula. Thank you very much for your patient listening.
That was a nice paper. Was this pulmonary hypertension treated?
No, sir. These patients were on, you can see table 1. These patients were on some drugs like ARBs and calcium channel blocker. None of them was on sildenafil citrate or any other endothelin antagonist like bosentan.
Okay.
So now that after diagnosing, after knowing that they have pulmonary hypertension, did you do anything with them?
No, sir. Actually, that's a different thing. Ideally, we have to do a right heart catheterization, and we have to see how far, whether it is pre-capillary or post-capillary. If it is pre-capillary, whether it responds to your vasodilator challenge, that is a different thing that we don't look at. Actually, we wanted to know whether the proximal fistulas are associated with higher pulmonary hypertension than distal fistulas. We didn't look at therapeutic aspects in this study. It was simply a cross-sectional study. That was a limitation. We didn't have follow-up. It was just a cross-sectional study. And we can only say that proximal fistulas are associated with higher pulmonary arterial pressure. We can never establish a causal link also.
The one issue we have to remember in this particular thing is the pulmonary arterial hypertension in the patient with CKD on dialysis also depends on left ventricular end-diastolic pressure. And this also will be guided by the blood pressure of patient, anemia, and the clearance that we achieve. So when you have a higher blood flow in the proximal fistulas, you can assume that the patient, those who are taking dialysis in the proximal fistula, will have a better clearance. So it will have a better hemoglobin. So we expect in such situation it will be much lower, the left ventricular end-diastolic pressure. So generally your conclusion is saying that the proximal will have a higher chance of pulmonary hypertension. I don't know what is the clinical significance of it. In fact, proximal will have a better quality of life with the better clearance, better maintenance.
The analogy is akin to a left to right cardiac shunt. If you have a atrial septal defect or a ventricular septal defect or a PDA, greater the shunt volume, greater is the risk of pulmonary hypertension. Similar analogy is there, and we cannot conclude anything, but we have to be cautious whenever possible. See, in this study, the most common vascular access was proximal fistula. And the DOPE-5 study, it observed that there is increasing number of proximal fistula being created even though there is a scope for initial distal fistula creation. So we can change the practice pattern. That is the only conclusion we can say at this point.
So yes, this is a cross-sectional quality. You have a limitation. Before that, we need to know the basic disease also, because what is the any pulmonary pulmonary involvement is there. Second thing, what is the ejection fraction of all these patients? Did you look into the ejection fraction?
Yes, sir. We looked at
See,
ejection fraction.
if you compare, sir, previously before creating the fistula, what is the ejection fraction
Yes, yes.
after this
In
one?
table 1, we have shown,
Yeah.
we have compared the ejection fraction in patients with proximal versus distal fistula, and that was not statistically different, sir. It was the same.
Yeah, how many? See, that's what, without affecting it, how it affect? I don't know. Really, the causal you told no that I don't know this one. Huh?
Ejection fraction, LV systolic dysfunction is a risk factor for pulmonary hypertension. So it can influence pulmonary hypertension. So in the regression, multivariable regression analysis, we have included ejection fraction as a covariate in order to account for the confounding by ejection fraction.
And smoking also include no confounder.
The smoking we have not included. So COPD, if the patient had known COPD, we had excluded. That's all.
Okay, as we are running short of time, we will allow one more question.
Actually, if I don't know, I've read it correctly or not. Your brachial fistula flow was 1100.
1200, sir. 1236.
1200 is a very high flow. Because of that high flow, probably they have developed the pulmonary hypertension.
That is our hypothesis.
Why was
that is
that?
our hypothesis.
Why was that flow allowed? Because if you have a, if
No,
you
sir.
are,
If you look at the literature, you will take any paper. It says the average blood flow near proximal fistula is close to 1100, 1200. It's nothing unusual. It's not an outlier.
No.
It's what we commonly see.
what we have seen our patients' blood flow, we cannot reach beyond 400 ml.
No, that is inadequate. See, basically, your AV fistula flow should be more than 500 to sustain adequate dialysis. If your AV fistula flow is 400, you will only give inadequate dialysis. And the literature clearly says, whether it is proximal or distal AV fistula, flow should be minimum of 500. And proximal fistulas, brachial fistulas generally are associated with high blood flow. 1400, 1500 is common in brachial fistula. This is nothing unusual, sir.
Okay, yeah, let us stop at that. Let us move to the next paper.
The next participant, Dr. Subramanian.
So good morning once again. I am presenting another paper, and this is a multi-center study. And this study is about the real-world survival of non-cuffed central venous catheters inserted for unplanned and urgent start hemodialysis in CKD. So unplanned and urgent start hemodialysis is a common scenario in CKD patients in India. So many of our patients present for unplanned and urgent start hemodialysis. So while a cuffed catheter is preferable to a non-cuffed central venous catheter, in the real-world setting, especially in the resource poor setting, and especially when your patient presents with a life-threatening emergency like pulmonary edema, we are left with no other option than a non-cuffed central venous catheter. So most of us begin with a non-cuffed central venous catheter. The KDOC clearly recommends in its vascular access practice guidelines to limit the use of these non-cuffed central venous catheter up to a maximum period of 2 weeks. But what we observe in the real-world setting is that these non-cuffed catheters are retained way beyond the 2-week limit, and most often they are used as a bridge to a functioning AV fistula. So in this study, which was a multi-center retrospective observational study, we have assessed the survival of non-cuffed central venous catheter using time-to-event analysis, and we have analyzed the different indications for CVC removal, and we wanted to assess the risk factors for premature loss of non-cuffed CVC. Specifically, we wanted to answer whether diabetic kidney disease increases the risk of premature loss of non-cuffed CVC. So this multi-center study was done across 4 centers. Patients undergoing non-cuffed central venous catheter insertion for unplanned and urgent start hemodialysis from February 2020 to July 2021 were included. Follow-up lasted till January 2022, and we used an open cohort design. So in these centers, non-cuffed, non-tunneled, non-pre-curved CVC made of polyurethane material was used, and the internal diameter of the catheter ranged from 11 to 12 French, and the intravenous portion, it measured 13 to 15 centimeter, depending on the vein that was cannulated. So this table shows the socio-demographic profile of the 4 participating centers. Out of the 4 centers, 2 were teaching hospitals. 1 was a public sector government teaching hospital. 2 were non-teaching private hospitals. So as you can observe, these centers, they differ from one another with respect to the socio-demographic profile of the patients, as well as with respect to certain practice patterns like skin preparation, like the antimicrobial lock solution, and like the threshold for CVC removal. It was all different from one center to another. However, if you look at an individual center, there tends to be some correlation or clustering of practice pattern and socio-demographic profile. So this provides an ideal platform for doing what is known as a multi-level analysis or a hierarchical analysis, which is what we did in this study. So the outcome that we want to measure was the survival of non-cuffed CVC, which we measured as time to removal using Kaplan-Meier estimate. So when we say CVC removal, it could be elective removal or a premature removal. So when we say elective removal, that means the CVC is no more needed. It has served its purpose. That means patient has been transitioned to another durable form of access like functioning AV fistula, or he has been transplanted. Whereas when we say premature removal, the CVC is removed even though it is still required to sustain dialysis, and it is removed because there is some complication like infection or mechanical complication. So elective removal is desired and premature removal is undesirable. And within any center, the rate of premature removal should be negligible. So we wanted to assess the risk factors for premature removal. Specifically, we wanted to answer whether diabetic kidney disease increases the risk of premature removal, and other putative risk factors like immunosuppressed state, CVC location were all included in the multivariable analysis. So we used Cox multivariable frailty model. When we say frailty model, that accounts for the hierarchical model or the multi-level modeling. So each center is provided with a random intercept to account for the within-center correlation. So a total of 433 non-cuffed central venous catheters were inserted in 433 patients, and the most common site of CVC insertion was right internal jugular, and the least common was subclavian. Mean age of the patients was 50 years, and 71% were men, and 26% had diabetic kidney disease as their native kidney disease. So this is table 1 that shows the difference between diabetic and non-diabetic CKD patients. So diabetic CKD patients were much older than non-diabetic CKD patients. And non-diabetic CKD patients had more number of CVCs located outside the right internal jugular vein. And non-diabetic CKD patients, many of them were immunosuppressed. So this is the Kaplan-Meier curve. This curve was constructed by taking into account both elective as well as premature CVC removal. So there were a total of 393 CVC removals out of 433 insertions. 80% of them were elective removal and 20% of them were premature removal. So if you look at the median CVC survival, it was 37 days. That is close to 5 weeks, which is way beyond the guideline recommended 2-week limit. So the important reasons for premature removal in this cohort, the most common reason was a mechanical complication like CVC malfunction or a catheter dislodgement or pericatheter bleeding, followed by a bloodstream infection. So this table shows the rate of premature removal. The rate of premature CVC removal was 4.5 per 1000 CVC days, and the rate of CLABSI was 1.7 per 1000 CVC days. So so this is just an unadjusted crude analysis. In the crude analysis, if you see, apparently it looks like patients with non-diabetic CKD had a higher rate of CLABSI and a higher rate of premature CVC removal. But when we did the adjusted analysis using multivariable Cox regression, we observed 2 things. Patients with diabetic kidney disease, they had a higher hazard of premature CVC removal, and right internal jugular location of CVC reduced the hazard of premature CVC loss. So in this curve, you can observe that patients with diabetic kidney disease, they were at least 1.5 times at a higher risk of premature CVC loss compared to non-diabetic CKD patients. So to summarize, in the real world, non-cuffed CVCs are most commonly used, and non-cuffed CVCs are retained for a median duration of 37 days. Especially they are used as a bridge to AVF creation. This is worrisome, this is bothersome, and this calls for action in terms of advanced care planning and advanced preemptive vascular access creation. And in this study, the rate of premature CVC loss was 4.5 per 1000 CVC days. Mechanical complications followed by CLABSI were the reasons for premature CVC removal. And patients with diabetic CKD, they are at heightened risk of premature CVC loss. And so if you have a diabetic CKD patient, you must quickly expedite the process of transitioning to a more durable vascular access. Thank you very much for your patient listening.
So, Dr. Subramanian, were there any patients that you sometimes, there are acute worsenings that happen in a chronic kidney disease. So did you
Yes,
have
sir.
any of such patients?
So that means the indication for unplanned and urgent start hemodialysis in this study, 80% were due to advanced uremia and 20% were due to acute on CKD. 20% urgent start hemodialysis in this cohort was due to an acute on CKD. And 80% had an unplanned urgent start hemodialysis because of profound uremia in the absence of advanced planning. They presented without any preemptive vascular access creation.
Okay. So let us move to the audience for questions.
Sir, did you look into the dialysis unit problem here, like technicians?
Yes, sir.
Because that is also important in class B, no?
Yeah. We looked at the putative risk factors for premature loss that we analyzed were adaptation of barrier precaution while taking bath. And we had to interview the patient to get this information. Secondly, handling of the CVC by non-trained staff, that is staff not from the dialysis unit. That was included as a risk factor in the multivariable analysis.
Because class B was 17% or something.
No, sir. Class C, here we have found out the incidence rate 1.7 per 1000 CVC days. It is the pooled data from all the 4 centers. It's not a metric of any center's performance.
Is there any difference between the centers, like private sectors and government centers?
Yeah, to account for that only, we have used a random intercept model, where each center is given a random intercept to account for what we are answering in this study is not whether this center is better than that center.
No, I'm not telling. See, whether this can be like... with
Very
good
much
data.
possible, sir, very much possible.
Yeah.
It's possible because, see, within the public sector hospital, most patients were from a low socioeconomic strata, where they may,
Okay.